Hi there. My name is Nino Mihatov. I'm one of the General Cardiology Fellows at MGH, and I thought, as part of the MGH CCU lecture series, I'd share with you an overview of PA lines. And for this talk, first off, I'd like to thank Raj Malhotra, who taught me about PA lines when I was a resident and helped develop this framework. I'll structure the talk in 4 different areas. The first is indications and contraindications for placement. The second is review the data that PA lines provide. The third is talk about daily management of PA lines when you're in the CCU. And the fourth is to spend some time understanding in depth the tracings that PA lines produce. And I'll start off by reviewing the indications, all of which are soft and not based in any well-developed evidence base, and then the contraindications. And I think about PA lines in 7 different clinical scenarios or diagnoses, most of which are relevant to the CCU. Think about the utility of a PA line in a patient with undifferentiated shock, or in a patient for whom we're seeking to employ tailored therapy to help improve their management. PA lines could be helpful in teasing out the etiology of pulmonary edema, whether it's cardiogenic or non-cardiogenic in etiology. They're useful in understanding the severity and etiology of pulmonary hypertension, in teasing out the presence of a shunt, in evaluating pericardial processes, and that's notable for restriction, constriction, or even regionalized tamponade. And lastly, they could help us understand the severity of valvular disease. And then I think about the contraindications for PA line placement, and I think I could group those into either relative or absolute contraindications. Relative contraindications are their coagulation status, the presence of a fresh pacemaker, and we often think of fresh as less than 6 months since placement. And the reason that becomes relevant is when the PA line is being advanced through the SVC into the RA, RV, and ultimately into the PA, there's a possibility, particularly when done blindly, that PA line can become looped into the pacemaker and dislodge it. Other relative contraindications, and when I say relative, I'm often thinking, should this patient have their line placed in the cardiac cath lab? Is the severity of their tricuspid regurgitation or RV dilation? And lastly, I asked myself, is there a left bundle? And the reason is that if there is a left bundle and you're floating a PA line, you could induce a right bundle and therefore cause complete heart block. Those patients perhaps are better served in the cardiac cath lab where the rapid deployment of a temporary wire can be performed. And then there are absolute contraindications. Those are fairly limited to a mechanical prosthesis, so you cannot float a PA line through a mechanical tricuspid valve, or the presence of an RVAD, a right ventricular assist device. So now that we've talked about the indications and contraindications to PA line placement, let's review the data that PA lines provide. There's 3 categories of data. The first is measurement of pressures. The second is saturations, particularly useful when assessing for the presence of a shunt. And then the third is cardiac output. And that could be in the form of a Fick measurement based on the mixed venous saturation the PA line is able to provide, or by thermodilution, which should be used cautiously in those patients with severe TR, pulmonary insufficiency, or a shunt. Now, I'll briefly review normal pressures for the sake of completeness. I'll create a rudimentary 4-chamber model of the heart. We have RA, RV, we have PA, and then we have pulmonary vein, left atrium, left ventricle. When I think about pressures, I think about them most commonly using the quarter, nickel, dime, nickel rule. So every value has to either have a pressure of 5, 10, or 25. I then start off by saying I know that the right atrium is the lowest pressure chamber in this circuit and therefore must have a normal pressure of around 5 millimeters of mercury. I also know that in diastole, the right atrium and the right ventricle equalize in pressure, and so then the diastolic RV pressure has to be about 5 as well. From there, I say to myself, well, in diastole, the RA and the RV are communicating, but there has to be a step up between the RV and the pulmonary artery because the pulmonary artery is closed. And therefore, I say the diastolic pulmonary artery pressure is maybe slightly higher than the RV diastolic pressure, so therefore it must be 10. And I know that in the absence of any significant pulmonary hypertension, the pulmonary artery diastolic pressure often correlates with the wedge pressure, which we use as a surrogate for left atrial pressure, and furthermore left ventricular pressure at end diastole. Then I say to myself, well, I know that the RV has to generate a pressure that is greater than the pulmonary artery diastolic pressure, so therefore that means the RV systolic pressure must be 25. And then I also know that in systole, the RV and the pulmonary artery pressure equalize, and therefore the pulmonary artery systolic pressure must also be 25. If you want to get really fancy, you could add the dollar rule and say that LV systolic pressure is about 100. We've now reviewed the data that pulmonary artery catheters are able to provide. Now let's move on to placement and daily management of a patient with a PA line. Placement is quite simple. First off, it requires the placement of a cordis and the technique and risks associated with that. And the second is flotation of the PA line. The principle in flotation really depends on two things. One is if you're advancing the PA line, the balloon tip must be up, and if you're withdrawing, the balloon must be down. You then follow the tracings to help identify your positioning up until you enter a wedge tracing, which we'll review in a second. And then with regards to daily management, first off, remember that there's a line in place and assess daily the data you're obtaining from the line and whether it is providing useful information that outweighs the infectious risk of the line. Second, take note of the depth of the line. If there's any concern about the fidelity of the tracement or the placement of a line, start off by looking at the patient's neck to seeing how deep it is today compared to when it was initially placed. Third, always trust the tracing over the chest x-ray. The chest x-ray is a static image of a dynamically moving catheter, and so chest x-rays from day to day can vary simply by virtue of the cardiac cycle. If the tracing seems good, and more importantly, if the catheter wedges 1.5 cc's of air, it is likely that the catheter is in the correct place. If it requires greater than 1.5 cc's of air or doesn't wedge with 1.5 cc's of air, then it's too shallow. And if it wedges with less than 1.5 cc's, it's probably too far. When you do have a chest x-ray, then just know that the line should fall in about the middle third of the chest. And so those are my cursory thoughts when I think about placing a PA line and managing it daily. Next, we'll move on to review both normal and pathologic tracings.